The forehead in this area is flat, but there are creases on this area. The eyelids are dropped, and here it's elevated. What's called the nasolabial fold is absent. Here it is well marked. The angle of the mouth is dropped. Here the angle of the mouth has moved to the half where the muscles of facial expression are working. The left side, the muscles of facial expressions are not working. In this patient, you can see that this eye is normal, this eye is larger because the orbicularis or oculi is not working, and the mouth is pulled towards the normal side. This side facial muscles are working. This is a newly born baby, and you can see the difference in eye opened here, eye closed. The mouth is deviated towards the right, so there is a left problem with the left muscles of facial expression. Even this kid is having a right problem in the muscles of facial expression, as well as this lady. The right muscles of facial expressions are working, the left are not. But this is milder. You can see the angle of the mouth deviated towards the right. You can see the nasolabial fold is well marked. A teenager. This problem affects all ages. If you look at this person, again, this lady and this lady, you can see that there's asymmetry of face. This baby is using his upper muscles of facial expression. He's raising eyebrows using occipitofrontalis, and his lower muscles of facial expression is using his orbicularis oris. Now, in the near future, next year, you are going to see these cases, different ages, mouth deviated to the left, that means the right is not working. Okay? For every problem, there is a solution. Okay? This deviation later on came to normal. One of the very serious problems is inability to close the eye. This young person can be able to close his left eye, but his right eye are still exposed. Now, we should take care of the unclosed eye, because this is going to lead to dry eye, inflammation due to dryness, and ulceration, especially of the cornea. Corneal ulceration is very painful, and consequences are very bad, scarring and problems in the visual field. This person has a right-sided facial problem, cannot close the eye. So what we do is that we usually give him artificial tears to drop into his eyes, and we patch the eye so that it does not dry. This This is called Bell's palsy. Bell's palsy is idiopathic facial paralysis. Idiopathic means no known cause, and it is the most common disorder of cranial nerves. Luckily, it gradually resolves over time. Luckily. And the cause is unknown. In this person, he has facial palsy on the left side, and the mouth is deviated to the right. But when he was investigated, it was found that he has tumor in the brain. So this is facial palsy. It is not Bell's palsy. When the cause is unknown, it is called Bell's palsy. When the cause is known, then this is facial palsy. This is what you are going to see in the future. Again, you will be asked to examine the facial nerve. In your introductory course to medicine, there is physical examination of respiratory system, cardiovascular system, nervous system, cranial nerves. Examine the seventh facial cranial nerve. You ask the patient to put up his eyebrows, examining the upper part of the muscles of facial expression, and close the eye forcefully, and you try to open the eyes. Examine the lower part of the muscles of facial expression. Close your mouth, fill your mouth with air, and you press on the cheek of this person, or show us the teeth using the levator labii and zygomaticus major and minor. Now, if we prepare you to the future, it's going to happen today. And we have to prepare you for the future. Now, the story starts here. Okay, this is the frontal air sinus, the central sulcus, in the motor area. Now, the body is represented in the motor area in this fashion, the homunculus fashion. Now, if this is the face, we look what is near the face representation. It is the thumb up and the tongue below. Therefore, if there is an upper motor neuron lesion of the face, check the thumb, the fingers, and the tongue. Very important. Upper motor neurons, they come through the internal capsule and through the corticobulbar tracts, and that of the facial nerve is affected by the thalamus and the globus pallidus. The globus pallidus is going to add effect of emotion, and it is called emotional pathway. If the lower motor neuron will not receive the emotional pathway, the face of the person is going to be featureless. You don't know if this person is happy or sad or anxious. This is called poker face. It's seen in Parkinson's disease as well. Yeah, Basha. story starts here of the lower motor neuron. Where are we? This is the floor of the fourth ventricle. This yellow nucleus is the motor nucleus. And this one is superior salivatory nucleus, which is parasympathetic. This nucleus is the nucleus of the sixth cranial nerve, abducent nucleus. And this nucleus, which is concerned about regulation of internal organs, this solitary tract nucleus. And this is the nucleus of trigeminal. And if we look in this area, inside the circle, it's the motor and the parasympathetic. Now, the fibers, على فكرة اللي بده يطلع خليه يطلع، الكل يطلع دفعة واحدة، لا كل شوية يتسلف واحد. يلا، لا تفيدون، لا تشوف ولا تسمع ولا تسمع. روح اتعلم يلا بسرعة. أنا ترى صرت أتعرف على بعض الوجوه تطلع. Now, the lower motor neuron will come out of the motor and turn around the nucleus of the abducent, making an elevation in the floor of the fourth ventricle, which is called the facial colliculus. The fibers, lower motor neuron, come out around the abducent nerve nucleus, turn, make an elevation, and then we have to look into the motor nucleus of the facial nerve, and there is a decustation of the upper motor neurons. Now, the motor nucleus of the facial is divided into two parts, superior and inferior. The superior neurons, they receive ipsilateral and contralateral upper motor neurons, and then they send lower motor neurons. The inferior part of the facial nucleus, supplying the inferior part of the face, these neurons, they receive only contralateral, and then they send lower motor neuron. If you look at this person, you draw this line. This is the upper face, this is the lower face. Now, in the upper face, here are the forehead creases. There aren't on the left. That means the right is working, the left is not working. The eyebrows are elevated. When he asked to elevate them, the left, they are not elevated. Plus the angle of the eyes in the lower face supplied by lower motor neurons of the inferior part of the nucleus. Here you can see obvious nasolabial fold, same way on the left. So the upper muscles of facial expression are affected, the lower are not affected. Even the angles of the mouth are at the same level. This is the testing of the upper part of muscles of facial expression. Raise your eyebrows using occipitofrontalis. Close your eye forcefully and try to open them. This is the test of orbicularis oculi. And this is the test of lower part of the muscles of facial expression. Close the mouth, fill the mouth with air, and try to push the cheek so that test the power of orbicularis oris, or show us your teeth. These are the central connections. Now, the facial nerve is going to exit between the pons and the medulla. So this is the pons, this is the medulla, these are the pyramidal swellings, these are the olive nuclei, this is the facial nerve. Just on the side of the facial nerve is the 8th cranial nerve. They are just adjacent to each other, and they come out through this angle, which is called cerebellopontine angle. Do we have to care about this angle? The answer is yes, because it's a common site for tumors of the brain. When they come out, the facial and the 8th cranial nerve, they run very short course in the intracranial part, and if this is the petrous part of the temporal bone, facial nerve and the 8th cranial nerve, they go through the internal auditory meatus. This is the internal auditory meatus. This is the internal auditory meatus, and this is the facial nerve. This is a CT scan of the area. These are the two lobes of the cerebellum. This is the medulla, and this is the facial and 8th cranial nerve. And in this area there is a more opaque area, probably a problem, probably something wrong is happening, but we do not know whether this is in the facial or in the 8th cranial nerve. Now this is the petrous part of the temporal bone, and this is the internal auditory meatus on both sides. That's the petrous part of the temporal bone. Look at this canal, or this area. This is the facial, and this is the 8th cranial nerve. Now, both of them run together, but here in this area, the facial nerve is going to leave the company of the 8th nerve and runs in a special canal called fallopian canal. Its own canal only for facial nerve. That's the petrous part temporal bone, and this is the special canal for the facial. The facial goes through this canal, and there is a ganglion here called geniculate ganglia. This ganglia is for sensations carried by the facial nerve. The facial nerve, after the fallopian canal, one way of its direction is that it goes into the medial wall of the middle ear. And this is the geniculate ganglia dissected. Again, the company of vestibulocochlear, 8th nerve, and the facial nerve. And this is the facial nerve canal in the medial wall of the middle ear. Because this is the middle ear, these are the ossicles, and the facial nerve passes in a canal in the medial wall of middle ear. Again, you can see this is the facial canal with the facial nerve in the middle ear. If we look at this pyramid, this is the place of a muscle called Sibelius. It is inside a bone. At the tip of the pyramid, a tendon comes out. This is its Sibelius muscle, and the facial nerve in its canal, as it's passing on its way, is going to supply the Sibelius. Therefore, we have to ask our patients who have facial palsy, is your hearing different? Hearing is not going to disappear, but because this muscle action is to affect the tension of the stapes, so we need to ask, is your hearing different or not? We underline the word different. We do not say, have you lost your hearing? No. Say, is your hearing different? Then, after the facial nerve finishes the area of the middle ear, it comes down on its way down out of the skull. It comes down. This is the canal of the facial nerve. The anterior wall of the mastoid process. These are mastoid air cells. So this is the facial canal becoming perpendicular on its way down. If this is the mastoid air cells in the mastoid process, then the facial nerve starts to come down. And it comes down in an oblique way on its way to the stylomastoid foramen, to come out of the skull. At this point, this is pure motor for muscles of facial expression. Again, this canal, and this is the stylomastoid foramen. That's the stylomastoid foramen, and facial nerve comes out on its way to muscles of facial expression, and it's pure motor. Now, this structure is the external ear, the pinna of the external ear, and some areas of the pinna of the ear has sensations that will be carried out by the facial nerve. So these sensory nerves will come and join the facial nerve. That's the stylomastoid foramen. This part of the facial nerve is purely motor. It enters the parotid gland, dividing it into superficial and deep part. This is purely motor. in front of the ear, entering the parotid gland. This is parotid gland dissected. And these are the branches of facial nerve, which should be preserved. Now, this is a representation of the 5 branches of the facial nerve: the temporal, the zygomatic, buccal, mandibular, and cervical. So the facial nerve equals what? What is well known or always spoken about is that it is motor. Some people say it's pure motor. It is not. Now this motor part goes to the muscles of facial expression. Plus another thing, another nerve attached to the facial nerve. And this is called nervus intermedius. Some people call nervus intermedius the 13th cranial nerve. Cranial nerve number 13. It is attached to the facial nerve. And it includes parasympathetic fibers, a nerve called the greater superficial petrosal nerve, which is going to affect secretions of the face. Secretions of the face meaning tears, secretions of the nose, and secretions of the mouth, because it is motor to salivary glands and lacrimal glands. The second part of the nervus intermedius is called chordae tympani, because it brings taste. It is sensory, special sensory, from the anterior 2/3 of the tongue. The third part of nervus intermedius is somatic sensory, coming from external auditory meatus, the auricle, and the retroauricular area. So the facial nerve is the motor part, parasympathetic and sensory. Parasympathetic, special sensory, and somatic sensory, they belong to the nervus intermedius. The nervus intermedius, having the parasympathetic part, as it comes through the facial nerve, has 2 parts. The part that goes to the tip of the petrous part of the temporal bone, it is called the greater superficial petrosal nerve. And then a second part that runs with the nerve as it passes on the medial wall of the middle ear. Then it's going to leave it, and then the facial nerve continues as pure motor. When the parasympathetic leaves the facial nerve in the middle ear, this is called chordae tympani. It is parasympathetic. It's going to leave the skull through special canal, and it is going to go to the submandibular ganglion to supply submandibular gland and sublingual gland. So this is part 1 of the parasympathetic system of nervus intermedius. Again, nervus intermedius, parasympathetic, comes through the facial nerve, passing through the fallopian canal, turning on the petrous part of the temporal bone, and this is the greater superficial petrosal nerve. You know this view, that's foramen magnum, that's the petrous part of the temporal bone, and the greater petrosal nerve coming from the middle ear through a special canal, then a tunnel bringing parasympathetic fibers. Now, inside the petrospartal temporal bone, there is the internal carotid artery. Internal carotid artery has sympathetic plexus in its wall. So a nerve comes from the internal carotid artery, sympathetic. This nerve is called deep petrosal and joins the superficial petrosal nerve. It's sympathetic, and we start having a nerve which has sympathetic and parasympathetic. This nerve is called median nerve. So it's the greater petrosal plus the deep petrosal يساوي median nerve. It runs in the median canal of the petrospartal temporal bone, ending up in pterygopalatine fossa. This is the median canal. This is a cross-section of the median canal. This is the median canal ending up in the infratemporal fossa. This is the infratemporal fossa, and this is the pterygopalatine parasympathetic ganglion, where the greater and the deep petrosal nerve are going to end. This is another slide of this area. Now, when cardi tympani runs in the middle ear, you have to ask and treat middle ear infection very, very well. Otherwise, facial canal and the cardi tympani will be damaged. This is a view of the middle ear. Here is the facial nerve coming into a canal on the medial wall of the middle ear, and we have seen CT scan of this canal. And at this point, cardi tympani is connected, passing in the middle ear. The cardi tympani goes through this canal, special canal for cardi tympani. As the facial nerve is passing into its mastoid part, it gives the cardi tympani, and the cardi tympani passes through the middle ear, and it goes to the lingual nerve. Now, where are we? This is the ear, this is the mandible, and this is the infratemporal fossa. This is the lingual nerve, and you can see the cardi tympani in the infratemporal fossa joining the lingual nerve. Again, this is the mandible, this is the ear. If you look into this area, the mandible is cut. You can see that this is the lingual nerve, and this is the cardi tympani. Parasympathetic fibers coming through the cardi tympani, and this is the tongue. These parasympathetic fibers are going to end up in submandibular ganglia and going to submandibular salivary gland and sublingual. Now, as long as we are here, taste from the anterior thirds of the tongue. They are carried by, first of all, lingual, and then they are carried through the lingual. That's the parasympathetic coming down, and taste through the lingual is carried by the carotid tympani. So, two modalities run in the carotid tympani. It's the parasympathetic going towards the mouth, and taste from the tongue carried in the opposite direction. So taste goes through the carotid tympani in the middle ear and joins the facial nerve. This requires the question when you examine the facial nerve. You ask the patient, is taste different? Is taste different? We do not say, has taste disappeared because the other side is working. Is taste different? Just like, is your hearing different or not? Carotid tympani in the middle ear runs in the tympanic membrane. Inside the tympanic membrane can be seen in a normal tympanic membrane. So that's the carotid tympani when it joins the facial nerve. This is what? This is a test of the upper part of muscles of facial expression, examining the superior nucleus. Using occipitofrontalis, okay? Raise your eyebrows, normal. Close your eyes forcefully. Try to open the eyes. Test of orbicularis oculi. And this is a test of the lower part of the facial nucleus. Or whistle to contract the orbicularis oris. Or show us the teeth using levator labii and zygomaticus major and minor. And don't forget to ask, how is your hearing? Okay, and if you have middle ear infection, treat it very, very well. Do you know how many times I've said this? So many times. Middle ear infection should be treated very well. Otherwise, facial palsy will result. This is a mind map showing the arrangement of the facial nerve, and this is on your e-learning. Okay? Thank you.